We are live now, we can begin.
So hello everybody and welcome to this exciting glaucoma session of the day. Our special focus today is on diagnostics and imaging, with just touching upon certain therapeutic topics as well. Joining us, we have our co-panelists, myself, Dr. Aisha, Dr. Ali Sheikha, and Dr. Abdul Wakil. And we've got an interesting variety of speakers who we're welcoming today. We're grateful that they were able to join us. Firstly, I'd like to welcome Dr. Ali Hafiz, who's an assistant professor of ophthalmology at University of Montreal and McGill University, Canada, to enlighten us about potential errors in our understanding of normal tension glaucoma. Please go ahead, Dr. Ali. You can share your screen.
Thank you very much, Aisha, and I really appreciate the invitation and be given the chance to join that fantastic group from Oman. I still hold the finest memories about the days I spent in Muscat a few years back. So today we're going to be talking about potential errors or misconceptions in our understanding of normal tension glaucoma. We know, as per definition, normal tension glaucoma is an optic neuropathy that shows disc excavation, visual field loss, open anterior chamber angles with statistically normal intraocular pressures. The percentage is somewhere between 20 to 30%. So 20 to 30% of open angle glaucoma patients show normal intraocular pressure. But we should take a small pause to discuss the scientific basis for the whole concept of normal or intraocular pressure. Is it the statistical average within the general population of 15 millimeters, and then with two standard deviations, we reach the upper statistical norm of 21, 22? Or is it more the pressure that should be compatible with the uninterrupted health and function of the eye? And actually, this is difficult to quantify because it can differ significantly between different individuals. We know that normal intraocular pressure may not be sufficient, as the case with ocular hypertension, or necessary, as the case with normal tension glaucoma, for development of glaucomatous optic neuropathy. And still, intraocular pressure remains a very important factor because it's the only modifiable risk factor, and it has been shown that it reduces the risk of progression by 2/3. And so we still hold it as an important risk factor. But there are other associations, other risk factors that have been identified, and these risk factors might have variable influence among different patients. This is a list of such risk factors. And now we tend more to look at glaucoma as a multifocal disease in which IOP-dependent and IOP-independent pathologic processes do play a role. And in case of normal tension glaucoma, it is more the IOP-independent pathologic processes that have the upper hand. So now moving to the three potential errors. The first one would be the failure to rule out non-glaucomatous etiologies of the neuropathy. The second would be failure to consider the non-IOP dependent mechanisms of the disease. And the third would be to rush to treatment, often aggressively, with no evidence of progression. Now, let's start by the first one, non-glaucomatous etiologies of the neuropathy. There is a term called normal tension glaucoma imitators, and these are glaucomatous conditions or non-glaucomatous conditions that tend to mimic glaucoma. They look like glaucoma. Among them is open angle glaucoma with high intraocular pressure and low central corneal thickness or low pachymetry, such as the case post-refractive surgery. Open angle glaucomas with intermittent or unrecognized pressures, high pressures, or secondary open-angle glaucomas post-pigmentary or post-exfoliation or post-steroids or post-uveitis. They can all mimic normal tension glaucoma. As for the non-glaucomatous disease processes, we have all different CNS lesions or masses, compressive neuropathies, ischemic neuropathies, vascular occlusions like artery occlusions or vein occlusions, and all those anomalous discs, whether they have myopic discs or hypoplastics or drusens, they can all again mimic normal tension glaucoma. I'm sure everyone is aware of these findings that suggest the possibility of a non-glaucomatous disease process, and mostly the disproportionate findings between the disc and the field, as well the vertically aligned visual field effects in case of neurologic or neuro-ophthalmologic conditions. Moving to the second potential error, the failure to consider non-IOP dependent mechanisms of the disease. For many years now, glaucoma has been looked at as being influenced by two major forces, the mechanical or pressure force and the vascular or ischemic force. And in reality, either force might be sufficient to cause glaucoma, but in most cases, it's a combination of both forces acting together that leads to the glaucomatous optic neuropathy. Cardiovascular conditions, cerebrovascular diseases, vasospasms, smoking, episodes of shock or blood loss, systemic or nocturnal hypotension are all conditions common to glaucoma patients that point to vascular insufficiencies. Vascular findings in glaucoma at the level of the eye has been reported back with George Spater's findings as regards impaired perfusion of the optic nerve head, also impaired circulation in the peripapillary retinal arteries. We all know disc hemorrhages identified by Stephen Drance from Canada, and as well as localized constriction of retinal arteries. Now, if we look at the systemic vascular findings in glaucoma, we find that a well-known study, the Baltimore Eye Survey, has linked between ocular perfusion pressure and glaucoma and reported a 6-fold risk of glaucoma for those patients with lower ocular perfusion pressure. So basically, there is an interplay between ocular perfusion pressure and intraocular pressure. As one increases, the other one decreases. As intraocular pressure increases, the ocular perfusion pressure to the optic nerve head decreases. And such a condition is regulated by a specific mechanism called autoregulation. There are many technical advances that have enabled research into abnormalities of ocular blood flow in glaucoma. And amongst them, color Doppler imaging, pulsatile ocular blood flow, laser Doppler flowmetry, laser Doppler velocimetry, fluorescein angiography, and ICG angiography. And all of these techniques have their limitations, have their advantages, but mostly the problem was that they tackle different aspects of the ocular circulation, starting from retroocular blood flow to bulk choroidal blood flow, to retinal microcirculation or retinal macrocirculation. And so we tended to measure different aspects of the same disease process. Most recently, OCT angiography has provided as well imaging for the parafoveal and peripapillary density, the superficial plexus and deep plexuses. And I think that Dr. Sommer is going to be addressing that point in details. On a different level, migraines and vasospasm. Vasospasm, we all know, is related to the constriction of the smooth muscles of the microcirculation. And again, 65% of patients with normal tension glaucoma have showed a positive vasospastic response. The collaborative normal tension glaucoma as well reported a 2.58-fold increased risk of progression in glaucoma patients suffering from migraines. This is a tracing of vasospasticity as assessed by the finger Doppler flow meter and immersion in cold water. And as you see, there is right in here, this is the tracing for a vasospastic person, and here a tracing for a non-vasospastic person, and shows the low baseline flow in here, as well as the rapid drop in flow following the exposure to cold water and the very slow recovery. In the other hand, in a non-vasospastic person, there is a sudden drop, but a sudden recovery thereafter. Systemic blood pressure as well has been associated with normal tension glaucoma. And the low pressure glaucoma treatment study has reported that normal tension glaucoma subjects have lower systemic blood pressure than open angle glaucoma, the high pressure glaucoma subjects. Patients with normal tension glaucoma are more likely to have periods of nocturnal hypotension as compared to controls. And that is an important risk factor for glaucoma. And on the other hand, lower blood pressure was found to be associated with progressive glaucomas compared to stable patients. And finally, to move to the third potential error, the rush to treatment, often aggressively with no evidence of progression. If we look at progression in the four major randomized clinical trials, the OATS, EMGT, CNTG, and AEGIS, we're going to find that normal tension glaucoma happens to have the second lowest risk of progression. So just below the ocular hypertension treatment study at 4.4, we have the normal tension glaucoma study at 12% progression. Way below early glaucoma and advanced glaucoma. The collaborative normal tension glaucoma study, one of the most important randomized clinical trials, has taught us many lessons. If this is a study that you know has compared two arms, an observation arm and a treatment arm, and aimed to reduce pressure by 30% reduction. By 30%. So what we have learned from that study: first, reduction of intraocular pressure improved the course of normal tension glaucoma. So IOP is still involved in its pathogenesis. Second, 50% of normal pressure glaucoma patients obtained a 30% pressure reduction with no surgery, just with laser and drops. Third, normal tension glaucoma patients with threat to fixation behaved identically in terms of speed to those who had no threat to fixation. Maybe this is the most important factor, most important lesson. 40% of NTG patients randomized to no treatment did not progress even without IOP reduction. 23 did progress in spite of IOP reduction for different reasons that we could elaborate on. Some patients with normal tension glaucoma progressed more rapidly than others, and a small group of these patients showed a rapid progression, and this is maybe the group that should be identified and should be treated aggressively. So in view of the great variability of the untreated disease, normal tension glaucoma patients should have the rate of progression determined and confirmed prior to any decision to treat. How do I treat normal tension glaucomas? First, I rule out the imitators of normal tension glaucoma, whether glaucomatous or non-glaucomatous. I do not rush to treat. I determine if these patients are progressing, then I evaluate. If progressing, I treat the intraocular pressure with a 30% reduction. And if, despite the apparent control, they are still progressing, I should consider the non-IOP dependent mechanisms. Finally, I carefully assess each case separately before going for surgery, because usually I should be aiming at pressures of less than 10 millimeters of mercury. Thank you.
Thank you, Dr. Ali.
That was excellent. That was excellent. It was very informative. We'll take questions from the audience at the moment, if there are any.
One question, Dr. Ali. This is most of the patient will not progressive if not treated, and if treated will progressive. How can I decide it? Only follow up the patient, and if the patient is progressive, should I treat? Otherwise, only follow up without the treatment?
Absolutely. So basically, yes, I do not rush to treatment once I see a patient, even if there is some evidence of damage, because sometimes this damage is related to a certain incident, an attack of blood loss, an attack of shock. But then it stays stable at that point. So I usually take my time. I follow up the patient closely by visual fields, by OCT, and I see if he's progressing or not. If he's not progressing, then I continue the follow-up. Maybe I can lengthen it according to how comfortable I am. But once I see any evidence of progression, yes, I should start a treatment, and at that point aim at 30%.
Thank you.
Thanks, Dr. Ali. That was very informative. So we'll welcome now the second speaker, Dr. Mazen Sinjab, who will talk about biometry in short eyes.
Assalamu alaikum. Bismillah.
Alaikum salam.
Is my screen visible to you?
Yeah, it's visible, Dr. Mazen. Can you start,
okay.
please?
Yeah. Bismillah, assalamu alaikum. I'd like first to thank the organizers for this conference, and at the same time, I'd like to apologize for not being able to present as much possible of presentations as usual, because I'm involved in preparation of the first refractive master class, which will be next year. Now, as an introduction, we were taught that this is the average eye. Actually, this is not correct. This is not the average. This is not the average eye, because it doesn't cover the whole spectrum of eyes in the normal population, apart from the abnormal population. So this is why there is a question: why plenty of formulas? Why do we have plenty of formulas and plenty of programs, softwares, in order to calculate the IOL? Actually, because of many variabilities, because we have short eyes and we have long eyes. We have eyes with abnormal anterior chamber, deep anterior chamber, but the posterior segment of the eye is normal. We have eyes with shallow anterior chamber while the posterior segment is normal. On the other hand, we have eyes with normal anterior segment, but a long posterior segment. And we have eyes with normal anterior segment, but with short posterior segment. In addition, there is lentiglobus. So the position of the lens, the thickness of the lens is not the same for everybody. What about the aphakia? What about the pseudophakia? And what about the biggie bag? In addition, it has been found that the angle kappa has an effect on measurement of astigmatism, which affects, of course, the selection of toric IOLs and the accuracy of the IOL calculation. Moreover, the status of the cornea, because if the cornea had previous myopic laser vision correction, previous hyperopic laser vision correction, previous presbyopic treatment, or RK, then it is an abnormal cornea and it should need special formulas. Otherwise, there will be miscalculations. What about those eyes filled with silicone oil? In addition, there are some differences between the, according to gender, because in male, in general, the axial length is 0.5 millimeter longer than that in comparison with the female, and the cornea is 0.5 flatter than the females. The IOL type, shape, and materials affect the IOL calculation as well, because there are a number of factors, such as the material, PMMA, acrylic, silicone, hydrophobic, hydrophilic, the function of the IOL, like monofocal, toric, premium, and the shape of the IOL at the same time. The white-to-white has, of course, a big role in the calculation of the IOL. So I'm going to take you through the evolution of formulas. In 1977, the IOL power was calculated very simply by adding the pre-cataract refraction to 19. And the achievement of plus minus 1 diopter in general was a very good achievement at that time. However, later on, the target of refraction post-operatively should be plus minus 0.5 diopters, and there was a target to cover the abnormal eyes at the same time. So several methods were developed, like the historical refraction, regression, vergence or Gaussian optics, ray tracing, and artificial intelligence, or a mixture of all. So the first generation of the formulas was in 1970s, where the anterior chamber depth was considered as a constant, 4 millimeters. Then the second generation in the 1980s, where the anterior chamber depth was not a constant, but it was a variable, but depends on the axial length. Then came the third generation in the 1988, where the concept of ELP was invented, and the ELP, which is the effective lens position, depended on K readings and the axial length. Then the fourth generation, which added more variables in order to more accurately measure the ELP, such as the lens thickness and the pre-op anterior chamber depth. And then the fifth generation. Now, as you see, the evolution from the first generation to the fifth generation passed through these steps. The number of variables versus constants were increased. The number of parameters included were increased. The inclusion of unusual eyes and the inclusion of abnormal eyes. Of course, we should stop using the first and second generation. We have to use the fifth generation, if available. If it is not, then the fourth or the third. This is just to show you that how much variables they are included day by day in order to increase the accuracy of the third, fourth, and fifth generation of formulas, in addition to the method they depend on, such as the artificial intelligence, ray tracing, and others. This is the most important slide, actually, that summarizes the ability of every formula in covering the axial length and covering the normal and abnormal anterior segment. Of course, I'm not going to go into detail in this slide, but however, we have to know that the lens constant is not a constant. So this is a misconcept. We think that the lens constant, the IOL constant written on the box of the lens, is a constant. It is not, because it depends on the IOL material. It depends on the IOL design, including optic and haptic design, IOL type, anterior versus posterior chamber, one piece versus 3 pieces. The surgeon has an effect on the IOL calculation as well during the operation, like the capsular axis size and concentration, incision size and position, inadequate OVD removal, and post-operative capsular back contraction and fibrosis. So the measurement devices, of course, we have two groups of measurement devices: the ultrasound, including the contact A scan and the immersion A scan, and the optical devices, including the partial coherence, interferometry, and the swept source. Of course, the most accurate is the swept source OCT nowadays. Now, based on what I said and on many other factors, I created this algorithm and I called it the ATISA, which is Available Technology and Eye Status Algorithm. Actually, there are, so far, I could create 10 ATISAs. One for normal eyes, one for toric IOL, one for axial IOL, myopia, axial hypermetropia, post-keratorefractive surgery, polypseudophakia, piggy bag, keratoconus aphakia, and silicone oil. Because this lecture is about the short eyes, I'm going to present the ATISA 4 for short eyes, which is usually high axial hypermetropia. The question is, do you have an optical device? Yes, I do. Do you have Barrett, Universal 2, or Hill, RBF formulas included in the optical device? Yes, then use them because they are the most accurate in short eyes. No, I don't. Okay. Do you have an online access? Of course, everybody nowadays should have an online access. However, yes, I do. Then you have to use Barrett Universal 2 or Holiday Consult IOL calculator, or you can use the Hill RBF. But if you don't, you still have a solution. For example, if you don't have an optical device, if you have an optical device, but you don't have an the Barrett 2 Universal and Hill RBF, and you still don't have an online access, okay, there is a solution. You can use the Hofer Q, which is the 3rd generation, but with optimized lens constant from the manufacturer. You have to contact the manufacturer and you have to ask them, what is your optimized lens constants for short eyes? They should give it to you and then you can use it. Or you can use the Holiday one, again, with the optimized lens constants from the manufacturer. Now, if you don't have an optical device, you have an ultrasound. The same question, do you have an online access? Okay, if you don't have, then you can go for either Hofer Q or Holiday one with the optimized lens constants. Or if you have an online access, you can go to Barrett 2 Universal, Holiday Consultant IOL calculator, but you cannot use the Hill RBF because it does not accept the parameters given by the ultrasound. Okay, how to go to the Hill RBF calculator? There are 2 versions. Now, version 3 is better. You just click on the link and you go, or you can search it online and you can find this calculator. You put the parameters that you got and you can get the calculation. However, the limitations of the Hill RBF calculator, it is designed just for specific shapes of lenses and specific range of power. So it will tell you, whenever you put your parameters, it will tell you, you can use it for so-and-so lenses and so range of power. If it is out of range, it will tell you you cannot use it. The Holiday IOL Consultant is an online calculator as well. You can put the parameters and you can get the calculation. The Barrett Universal 2 formula, it is available as well. And there is the Toric calculator and others as well. So to sum up, you can use this algorithm in order to get the most accurate measurement of the IOL calculation. So there is no excuse. If you don't have an optical device, you have an ultrasound, there is a solution. If you don't have an online access and you have the 3rd generation of formulas, you can calculate the IOL. But don't use the 1st and 2nd generation of formulas. And thank you very much. I'd like to invite you to the module 1, which will start on 1st of February. It will last for 2 months. It will go into detail and the diagnostics, including the biometry as well. Thank you very much.
Thank you, Dr. Mazen. Thank you, Dr. Mazen, for this nice presentation.
Thank you very much. I stopped sharing or not yet?
Yeah, already stopped.
Okay,
but
good.
This is if there another speaker. Yeah. Dr. Aisha will start now. Dr. Aisha is a consultant for a glaucoma consultant in the Sultan Qaboos University Hospital. Please, Dr. Aisha.
So to continue along the lines of Dr. Mazen, wavelength of small eyes, I'm addressing how to manage glaucoma in the nanophthalmic eye. So nanophthalmus is a simple form of microphthalmus, which is not associated with any other ocular anomaly, where you have a short axial length and a relatively small anterior segment, which may be associated with a small corneal diameter less than 11 millimeters and a thick sclera choroid more than 1.7 millimeters posteriorly. Now, there's no consensus with regards to the cutoffs of axial lengths for nanophthalmic eyes. Historically, there was a strict criteria of less than 18.5 millimeters, but relatively in the recent years, that has gone up to even up to eyes of 21 millimeters. These eyes are very highly hyperopic. They have a thick iris with a lot of iris convexity and a very, very high lens to eye volume ratio. Now, the cause of this, it usually occurs due to the arrested growth of the eye in early embryogenesis. It can be either isolated or part of a syndrome. It has a very strong genetic basis, and it gives rise to a broad clinical spectrum of diseases. Now, the underlying pathophysiology is that you have anomalous abnormal collagen fibers, which, as you can see here in light microscopy image A, you have densely packed fibrils, which are very irregularly arranged. This gives rise to increased thickness of the sclera, with its inelasticity causing compression of the vortex veins and decreased permeability, obviously in comparison to the normal sclera below, which is image B. This causes these eyes to have a propensity for uveal effusion syndromes and even exudative retinal detachments. So recently we encountered a 29-year-old male who's monocular. His only functional eye is the left eye, who comes to us because of decreased vision for 2 weeks. This was preceded by a history of pain and redness in the same eye for 1 month prior to his presentation to us. In both eyes, he's known for retinopathy of prematurity, RD, and total blindness in the right eye for many, many years. He's taking thyroxine for hypothyroidism, but no other medical conditions. Visual acuity on presentation was hand motion, which has decreased from a baseline of count fingers, and a high pressure at 42. He has bilateral nystagmus, and in the right eye, microcornea, a small pupil, and a dense cataract, which is the non-seeing eye. In the left eye, which is the eye with the complaint, he's got mild conjunctival hyperemia, a somewhat clear cornea, a fixed mid-dilated pupil, and as we can see here on the image on the right, a very, very shallow anterior chamber depth, hardly half a corneal thickness width. And obviously he has a bit of posterior synechiae, some NVI on the iris, and a cataractus lens, more of a cortical cataract. Gonioscopy, we're unable to see any structures visible, even with indentation. Fundus, we were able just to see the posterior pole. There were sclerosed vessels, no active neovessels, and some laser-like scars a little bit in the periphery. So the patient had biometric measurements that go with a clinical picture of nanophthalmos. We see here a very small axis length of 19.3, a shallow AC depth of 2.2, not so much of a lens thickness at 4 millimeters, but very, very high K readings. And we actually measured the corneal diameter, and it was 10.7 millimeters in the clinic. So the patient basically is a young patient who's monocular, has nanophthalmos, nystagmus, cataract, and an angle closure glaucoma in the left eye. Now, this could be either due to a primary mechanism from pupillary block. As we know, these eyes have a very high high lens to eye volume ratio, enhancing iridolenticular contact, and therefore have a propensity to pupillary block. They could have plateau iris syndrome as well. And we shouldn't forget the posterior pushing mechanisms with secondary angle closure, such as uveal effusion or malignant glaucoma, which basically causes the anterior rotation of the ciliary body, pushing the iris against the trabecular meshwork. The incidence of angle closure in these eyes is very high at 69%, with an age of onset between the 3rd to 6th decade of life, which is in concordance with the normal growth of the lens with age. We performed a B scan to rule out any secondary uveal effusion causing a secondary glaucoma, and sure enough, there was none. There was no annular effusion. There was no choroidal thickening at the back. And so we went for a stepwise approach in management. We lowered IOP medically with aqueous suppressants and systemic medication. However, we do realize there's a limitation of success of medical treatment in these eyes, even after opening up the angle, because they're just the inherent structural changes within the drainage system. We performed an LPI, or we attempted to perform an LPI in order to relieve the relative pupillary block component. And post-LPI, there was a very small transient effect with the LPI. So pressure reduced slightly, and the chamber deepened slightly centrally to about 1.5 central corneal thickness wide. But on follow-up, his pressure was intractable. It was 58 millimeters of mercury. We were questioning the patency of the PI, whether it was small or not. And now the question is, what next? We know that argon laser peripheral iridoplasty is recommended if the angle remains closed after iridotomy. However, in these eyes, both lasers are effective only early in the stage of disease. They may not regulate pressure later on when PAS has already set. And so what is the subsequent management option that you would recommend? Would you do phaco and PCIOL? Would you combine phaco and TRAB, combine phaco and a tube, or combine phaco and non-penetrating deep sclerectomy, or even a cyclodestructive procedure at this point? Well, we know with any intraocular surgery, these eyes have a very, very high risk. Now, with any surgery that causes any changes, sudden changes in dynamic pressure, glaucoma surgery being one of them, very big complications can occur. And with filtering surgery, the high risk of complications are there, as well as risks of failure. 86% of eyes in a study in 1986 suffered continuous vision loss after trabeculectomy, and 60% of them did not achieve IOP control. In fact, another study more recent in 2008, where they combined a trabeculectomy with an inferior sclerotomy to prevent uveal effusion, showed success at 1 year, 85, but that has decreased at 5 years to 50%, with a very, very high rate of choroidal detachments initially. Now, if you do need to do a trabeculectomy, make sure you modify your approach. You can use mitomycin C, but make sure you have a tight closure of the flap. You delay laser suture lysis. You can even put pre-placed releasable sutures that you can slowly release with time, and a tight uniform closure of the conjunctiva. Now, what about glaucoma drainage devices? You would use a small sized tube if needed, because these are small eyes, and you could even employ a complete tube ligation initially until capsulation takes place in order to prevent hypotony. Non-penetrating surgeries, there's no dramatic decompression of the globe, so there's a positive there. However, they don't really achieve adequate IOP lowering. With cyclodestructive procedures, they're very pro-inflammatory, especially the transscleral diode CPC. And in these eyes, they're very prone to inflammation. And so you'd reserve it for advanced high-risk cases. ECP could be done, which is endocyclophotocoagulation, a limited ECP at 180 degrees in order to limit the potential risk of hypotony. So alternative surgical techniques have gained popularity in recent years. So what they recommend now is with the improvement of cataract surgery, they recommend solo cataract extraction in these eyes as a first surgery. And we know that it's technically difficult. There's very high risk of complications and unpredictable visual outcome. And due to the small working space and the positive pressure, you're at risk of PC ruptures, iris prolapse, and a myriad of posterior segment complications such as malignant glaucoma, uveal effusions, and retinal detachments. However, it is worth a try initially. So is phaco consistently effective? We do know that there is a role for lens extraction in these eyes, and there's strong evidence that backs us up morphologically as well as at IOP reduction. However, and the pro that you can even add gonial saniculitis and ECP to the surgery in order to get a bit more pressure reduction. However, it's not always successful in nanophthalmic eyes. The incidence of postoperatively elevated pressure is very high in these eyes compared to normal eyes. So it's not useful in dealing with chronic PAS, even if you include GSL within your surgery. It's just because of the intrinsic dysgenesis of the outflow pathways in these eyes. So here we decided to go ahead with a solo phacoemulsification, a standard approach, clear cornea under GA. We don't want to use a retrobulbar block here. You want to make sure you control inflammation, IOP, and BP before you start. In order, these are contributory factors to develop a uveal effusion. And in order to minimize positive pressure and deepen the AC, we gave IV mannitol 30 minutes before surgery. Here we perform a partial sclerotomy in the superior quadrant, as you can see here, just in case we needed to use it in order to do a limited vitrectomy to deepen the AC. However, we didn't need to, because with the medical dehydration of the vitreous, we were able to deepen it sufficiently and perform uneventful surgery. Here we're using trypan blue to stain the anterior capsule. We're using a very highly retentive viscoelastic Helon 5 in order to deepen the chamber, and we're doing viscomydriasis here. We want to make sure you don't want to flatten the AC at any point here. You want to maintain the stability of the anterior chamber in order to avoid complications. The capsulorhexis was very tough. There was a lot of positive pressure that we encountered, and we had to stop multiple times during the capsulorhexis, even with a good technique, in order just to refill and overpressurize the eye with viscoelastic. We can see here, it's a bit of a struggle there. We're trying really to create that optimal capsulorhexis all around. Using Helon 5 was a real savior here in order to really overpressurize the anterior chamber. And so after that, we want to egress a little bit of that OVD in order for us to perform, as we can see here, egressing a little bit of the OVD and some fluid in order for us to perform a very gentle hydrodissection without risk of rupturing the posterior capsule. Phaco, you go in with the phaco tip, which we'll see in a bit. At position 0, you really don't want to cause any iris prolapse. And you really want to try to phaco in the interpupillary plane. so not really close to the corneal endothelium, and liberal use of viscoelastic. Here we have a bimanual cortical removal. It was also uneventful. We weren't able to polish the capsule though. We didn't want to risk anything there, and very high intraocular lens power is inserted. And this is useful. Lenses have been found, they've been found that they were very, very beneficial into stopping the posterior pressure and really pushing things backward. Although there's not much of visual gain here. And obviously, whenever here we coupled this treatment with an IZVH, which is a radiozondular hyaloid vitrectomy, where we went ahead with a vitrector and cut through the peripheral iris iridectomy here, cutting through the capsule, through the zonules and into the anterior hyaloid face, disrupting the anterior hyaloid, and a little bit of a vitrectomy there as well. So creating a unicameral eye, preventing potential for malignant glaucoma, and obviously ensuring a closed system, which is pressurized at the end with tight sutures, really filling the eye with viscoelastic before we go out with our irrigation. Here we make sure that we really have a tight closure of the conjunctival wound. And the patient is doing great. It's been a month after surgery, pressure's been down, there's no sign of malignant glaucoma so far, and we're keeping a watch on him. But definitely it's something to consider in these eyes with a surgical technique to optimize surgical outcome. Thank you very much.
Thank you, Dr. Aisha. Now can you stop sharing, Dr. Aisha, please? Dr. Abdul Wakil, we not both time, Dr. Abdul Wakil, can you, Dr.
Yes,
Abdul
please.
Wakil, can you call the next speaker?
Yes, okay, thank you very much. Next speaker will be Mr. Basil, Dr. Basil Alfouri. He will present combined procedure advanced congenital glaucoma. Dr. Basil, please share your slides. Thank you.
Assalamu alaikum, good evening, and first I will thank the organizers to invite me to be with you today in this glaucoma session. Indeed, my talk today will be about combined procedure for advanced congenital glaucoma cases. Congenital glaucoma is a rare disease. It's about 1 to 10,000 live births in Western countries, but in the Middle East, the incidence is more. It's about 1 to 2,500 live births. Anyway, it's a very important disease and one of the challenging cases which we can face during our practice. We can classify congenital glaucoma upon Shaffer classification to primary congenital glaucoma, glaucoma associated with congenital anomalies, and secondary glaucoma in infants. Primary congenital glaucoma also, we can divide it to true and infantile and juvenile. The congenital anomalies associated with the glaucoma: aniridia, Sturge-Weber, PHPV, Axenfeld-Rieger syndrome, Peter anomaly, and microspherophakia. All of these will make the glaucoma more advanced and more complicated in pediatric group. And as we all know, the management is always surgical for congenital glaucoma, as medical treatment can be used for limited time. And the surgical procedures which advised for glaucoma, first of all, trabeculotomy, either interno as goniotomy or externo as trabeculotomy. Trabeculectomy also can be done for congenital glaucoma, but it's preferred not to be the first surgery or primary surgery for these cases. Drainage shunts, valved or non-valved, also can be done for glaucoma in congenital cases, but also not as a primary procedure. Indeed, I will concentrate about the advanced cases in the Middle East we can face, maybe more than in Western countries. Trabeculotomy, indeed, we found that it's doing well with us. This procedure first described in 1960 by Smith. And indeed, we can talk about some advantages of trabeculotomy. First, it has a higher success rate than goniotomy or trabeculectomy. Many studies show that this high success rate. In one study, trabeculotomy achieved pressure control in 60% to 76% of juvenile and 96% of infantile glaucoma. Data from Chinese retrospective study reported that this procedure can lower IOP less than or equal to 21 millimeter. After trabeculotomy, the success rate was 91 and 87 among children aged 1 and 3 years respectively. The data from Western countries in 80s reported that 75 to about 90% reduction success of IOP can be achieved by this procedure. Second, it can be performed in cases with edematous cornea or in cases with poor visibility to the anterior chamber. Trabeculotomy is anatomically more precise, re-establish communication between the anterior chamber and the Schlemm, canal Schlemm. No introduction of sharp instruments across the anterior chamber. Trabeculotomy also seemed to be particularly effective in the case of aniridia, although Schlemm canal may occasionally be absent in these eyes. But as the incidence of primary congenital glaucoma in our area is higher than Western countries, and most of the cases in our area coming with cloudy cornea. So combined trabeculotomy with trabeculectomy can carry higher success rate for these cases. So this procedure now has been touted as a primary treatment for pediatric glaucoma in India and Saudi Arabia. Also now we are in Syria in Eye Surgical Hospital. We are doing this procedure for these advanced glaucoma, congenital glaucoma cases. This procedure started by creating a scleral flap, then doing a radial incision to reach the canal of Schlemm. After being sure that we can see the lumen of the canal, we can use the trabeculotome through the canal of Schlemm, then doing rotating into the anterior chamber about 45 to 90 degrees left and the same to the right. So by this, we finished trabeculotomy. Then we can do ectomy by removing the trabecular meshwork and doing peripheral iridectomy. Then we can suture the flap and close the conjunctiva. Many studies and articles. The most important one from King Khalid Eye Specialist Hospital in Saudi Arabia showed that the success rate was about 2/3. 95% of corneas were opaque, indication severe glaucoma. Patients with anterior segment abnormalities fared worse than other. And through this study, we can see that this procedure carry high success rate. Another important study comparing trabeculotomy by combined trabeculotomy with trabeculectomy. And the most important or the most or the conclusion of this study that trabeculotomy and combined procedure carry high success rate, but the combined procedure was associated with long-term success more than trabeculectomy alone. Another success study about combined procedure, all of them conclusion that combined procedure, trabeculotomy and trabeculectomy for advanced glaucoma, congenital glaucoma, when the cornea opaque and the diameter of the cornea greater than 12 millimeter, this procedure will be giving us lower IOP for long term for these patients. Thank you very much.
Thank you, Dr. Basil, for this. You are on time. Thank you. Please stop your sharing your screen. We are behind the time now. We call Dr. Hassan, and after Dr. Hassan, please, Dr. Aisha, we call Dr. Somar, because Dr. Basil Qadoura have two presentation, can connect two presentation okay, directly to save more time for sharing the screen.
Okay.
Please, Dr. Hassan. Dr. Hassan Khalid, okay. Consultant ophthalmologist in Al Maghribi Eye Center, Mecca. Please, Dr. Hassan, please start.
Okay. Thank you, Dr. Ali. I would like to thank the organizer to invite me to speak in this glaucoma session. My presentation will be a video of Ahmed valve about the false impression about the tube length while doing the surgery. This is a case of a neovascular glaucoma. As you see, I started with 7-0 Mercilin traction suture, then dissecting the conjunctiva. Then this is a new technique in inserting the plate of Ahmed valve. You can fix the suture first about 10 to 12 millimeters away from the limbus with 7-0 Vicryl, as you see, through the sclera. Then after that, you can thread the suture in the hole of Ahmed valve plate before inserting this plate underneath the conjunctiva. As you see now, I have two sutures through the sclera. Now it's the time to insert the plate of Ahmed valve underneath the conjunctiva. In this way, I think you can saving time and you can feel more comfortable. No need to ask your assistant to fix the plate in its place while taking the sutures. Some doctors ask me, why are you using Vicryl suture in fixing the plate? Why not nylon? Usually I start to use the Vicryl about 10 years till now. All my cases is good. There is no migration for the plate. I think that the plate will be fixed well after the capsule fibrosed happened. Now cutting the sutures. Tying the other sutures in its place. Now it's about 12 millimeters away from the limbus. The plate is fixed very well. Now it's time to create a scleral flap. I use bipolar cautery first to mark about 5 to 5 millimeters. Then highlighting by using the super blade and doing the scleral dissection. You can see the flap. Now you can see entering the anterior chamber about 1.5 to 2 millimeters from the surgical limbus into the anterior chamber using 23 gauge needle. Now it's the time to cut the tube. Here is, you can see I'm cutting the tube. After cutting the tube, I found myself that the tube is smaller than or shorter than what I need. It's very important to release the traction suture before cutting the tube. Usually I release it, but here I push the eye posteriorly to see superiorly. Now, what is the next options? There are two options: release plate sutures and make plate advancement, or use the tube extender. But actually, I don't want to push to any of these options. My decision was to insert the tube first to see if it's really shorter or it's just false impression about that. You can see after insertion the tube has a good length. You can see it's about more than 1 millimeter in the anterior chamber. It's clear. So my message here is don't rush to change before to change your decision before you try to insert the tube into the anterior chamber. After that, you can use also 7/0 vicryl to suturing the scleral flap. You can make 2 sutures in the corner and also another 2 sutures in either side. Then also 2 sutures to secure your tube. It's just parallel to the tube, as you see. Now the tube is implanted into the anterior chamber and fixed very well, but I see there is transparent, the tube is transparent through the scleral flap. So I also put fascia lata just over the tube and I suture it with 7/0 vicryl, only one near the limbus and another suture, and I leave it posteriorly. I don't suture by the end of this fascia lata. As you see, only 2 sutures at the limbus and another 2 sutures just at the level of the starting of the scleral flap. Now cutting the sutures and suturing the conjunctiva. Also the same 7/0 vicryl. The patient will complain during the first months of the surgery from foreign body sensation because of the tails of the sutures. Now you can see the length of the tube inside the anterior chamber. It's very nice. It's not short. But when I cut it, I felt that it's shorter than what I need. You can see now it's very good. Here is the patient on the next day. You can see the tube. You can see also the place of the plate. Everything went well. So my message here is don't rush to change your decision before trying to insert your tube into the anterior chamber, and thank you for watching.
Thank you, Dr. Hassan.
I just to add to that, sometimes you get a false impression that it's too close to the iris, and you want to your knee-jerk reaction is to change it and reinsert it closer to the cornea. But when you reinflate the eye later on, you realize that the original one closer to the iris is not too close, and you could have done very well on the iris. So yeah, false impressions do occur.
This is for me. I always better if you have anything to cover the tube is not to make the flap, because usually when you make this is not to make a flap, you find this is as more thicker way to enter the tube through the sclera to the anterior chamber. On that time, you can control the direction of the tube inside the eye more better than to make under the flap. In this case, if you need to make the flap, I make shorter, the flap is closer to the limbus, but after that I make with the crescent a reverse tunnel, and after that I open and enter all the tube from the behind to the anterior, all the tube under the sclera. And this is more safe to cover all. Not this is after 3-5 millimeter, you find this is this edge. This is this edge with the eyelid is or the eye movement up down. You find there is rubbing. On the future, you have more risk for exposure. For that, if you need to make this is under the flap, is better. Can you make here shortly? And after that, with the crescent, can you go to along the tube and open at the end 1 millimeter before the blade, and can you enter all the tube under the sclera, and this is more safer in my opinion.
Dr. Ali, let me share my experience with the insertion Ahmed valve tube. Indeed, I'm doing a small flap, small scleral flap, 3 by 3 millimeter. I found that I'm doing it a thin scleral flap. By this flap, sometimes I can manipulate the direction of the tube inside the anterior chamber. For example, after the insertion of the tube and forming the AC, if the tube is directed down to the iris, I am putting 2 sutures on the corners of the flap and stretched them. This will help me to make the direction or the tube in the anterior chamber up or parallel to the iris. And if the tube directed up to the endothelium of the cornea, I'm doing the suture loose or not suturing the flap. By this way, the tube will be a little bit down. And then I can cover the rest of the tube by scleral graft patch, for example, and avoiding putting the graft close to the limbus to prevent any dealing for the cornea in the future. This is my experience by inserting this tube.
Thank you, Dr. Bassel.
I have only one comment. The problem is not if the tube close to the cornea or close to the iris. Actually, to avoid this point, it's very important while entering the anterior chamber to go just parallel to the iris and just superficial to the iris. While the bevel is up, there is no risk to occlude the tip of the tube by the iris, and it should be supposed to be away from the cornea. The main problem in this video that cutting of the tube give me a false impression that it is shorter than the usual length. I think also one important thing that it's very important to release the suture of the traction suture, and push the eye to be as a patient in primary position. And at that time, you can calculate the length that you will cut the tube. At that time, you will have a good length. I don't think that it will be shorter or longer. It will be normal.
Thank you, Dr. Hassan. This is now 23 years. I implanted Ahmed glaucoma valve, and after that, always I cut it longer and try inside the eye. And after that, this is cut as usual, especially if you wanted to implant it in the posterior chamber. Now we are beyond the time. Please, Dr. Somar, can you sharing your screen?
Are you able to see my screen?
Yeah, Dr. Aisha, can you introduce Dr. Somar of you?
Yes, Dr. Somar Hassan will be talking about OCT angiography in glaucoma. What should everyone know?
Okay, thank you for the invitation. I will go through the presentation fast. What is OCT angiography? As we all ophthalmologists know, this is a non-invasive dye-free examination which allows us to assess the vasculature of the retina and the optic nerve, qualitative and quantitative. We can see the large vessels, the microvasculature, and parts of the choriocapillary plexus. The principle is easy. The mechanism looks for moving particles, mainly blood cells, and through the moving particles, we have a high variance of OCT signal between scans, and this variation is used to identify vessels. There are different algorithms which are used to interpret the variation between scans, and this leads to a high variation between different providers. What are the glaucoma-related structures which can be scanned by OCT? The optic disc region, the main region which we examine by glaucoma patients. Generally, we examine an area of 4.5 by 4.5 millimeters centered on the optic disc. And there are different slabs which found to be useful in the diagnosis and follow-up of glaucoma. Mainly, the most important slab is the radial peripapillary capillary slab, the RPC. These are the vessels which are located within the retinal nerve fiber layer. Another important step is at the choroidal level. These are the choroidal vessels at the parapapillary region. Another area is the macular region. We know that the macula is a very indicator for the progression and for the diagnosis of glaucoma. Normally, we examine an area of 3 by 3 or 6 by 6 millimeter centered on the macula, and mainly is the superficial level of the vasculature important. What are the parameters which are available for OCTA in glaucoma? The flow index is the average decoloration values of the measured area. The most important is the vessel density, which is the most widely used parameter in the OCT angiography. This is the percentage area occupied by vessels in the measured area. How much vessels are available in the measured area? Again, quantification methods differ between different providers, and this leads to discrepancies among investigations, and the measurements cannot be used interchangeably, which we already know by the conventional OCT. The parameters, this is an example of an eye with a glaucoma, how the OCT angio looks like. We see in the inferior temporal quadrant that the vasculature, the vessel density is low, and we see in the pseudomap that the thickness or the vessel density is reduced. When we control the glaucoma patients with normal eyes with controls, we see a reduced flow index and a reduced vessel density of these eyes compared with controls. This is true in the optic nerve head region, the optic nerve slab, but this is also true in the peripapillary region. And the most studies which compared the two groups with each other, the glaucomatous eyes and the normal eyes, found a significantly reduced flow index and vessel density in the papillary area. Even when we consider the glaucoma suspect patients, we see that these patients or these eyes even have a lower vessel density and a lower flow index compared with normal patients. This is even lower in the glaucoma, but even the glaucoma suspects have a reduced vessel density. In the macular region, we see a reduced vessel density in the superficial retinal slab. And very important is the microvasculature dropout sign. This is a sign which we see in the parapapillary area on the choroidal level, and it means the loss of choriocapillaries localized in the parapapillary area. We see it using this image in the inferior image. And this seems to be a true perfusion defect and not a measurement defect. In other forms of glaucoma, outside primary open-angle glaucoma, we see similar changes in the angle closure glaucoma. We see in the PICS patients, in the pseudo-exfoliation glaucoma, reduction of the superficial vessel density, which is greater than that found in the primary open-angle glaucoma eyes, even when comparable severities are taken into consideration. In the PICS patients, we see, contrary to the primary open-angle glaucoma, less microvasculature dropout in comparable severities. When we compare the conventional OCT with the angio-OCT, we find that the intravisit and intervisit reproducibility of the OCT angio ranges between 2.5 and 6.6, and this is measured in normal eyes. In glaucoma eyes, this reproducibility is even lower. The conventional OCT has a reproducibility of about 1.5%. This means the OCTR is less producible than the conventional OCT. And this is very important when considering progression detection, as the minimal changes which can be seen in the follow-up can be explained through the low reproducibility, and this might not always be a real progression. In high myopic eyes, we have a better association of OCT angiography with the visual field than the conventional OCT. And in high myopic eyes, the conventional OCT is not always exact as we see it in the OCT angio. The diagnostic ability, when compared with conventional OCT, we're speaking about the retinal nerve fiber layer and the ganglion cell complex. Considering the area under the curve and the sensitivity at high specificities, we found in the different studies different outcomes. The most studies are reporting about a better diagnostic ability of the conventional OCT, not the OCT angio. Considering the retinal nerve fiber layer, we found a better diagnostic ability when we compare this with the vessel density of the peripapillary area. The measurement of the ganglion cell complex have a better diagnostic ability when compared with vessel density of the macula. And other studies found comparable diagnostic abilities, but as we said, the most studies are reporting better results for the conventional OCT. This is one of the studies. We see the dotted line is the conventional OCT. This is the neuroretinal rim, and the continuous line is the vessel density inside the disc. And we see that the measurement, the sensitivity at 95% specificity is better for the conventional OCT. Exactly the same in the parapapillary region and in the macular region. In severe glaucoma, we found a better association of OCT angiography with visual field than conventional OCT. This is very important. Even important is that the floor level of the OCT angiography is lower than the conventional glaucoma. We have always with the conventional OCT a real problem when we examine severe glaucoma patients, as we reach the floor effect, and we cannot tell if the disease is progressing or not, even if the visual field is progressing. This floor level is by the OCT angiography significantly lower. Some studies report no floor effect for the OCT angiography. And this might mean that the OCT angiography might be suitable for monitoring progression in severe glaucomas, but we have always to be careful about the lower reproducibility, which might limit this. In the superior diagrams, we see the progression of the disease. The y-axis is the x-axis is the visual field defect, and the y-axis is the OCT angiography. And we see that as the disease progresses, we can hardly see a floor effect. Comparing that with the conventional OCT, the nerve fiber layer, we see a clear floor effect, which we all know in the practice. Regarding progression, are we able to detect progression using OCTA? This is a new technique, so we don't have long-term studies of progression, but we have the limitations. The OCTA, as said, has a less reproducibility and repeatability and varies with IOP changes. This is a measurement for the amount of vessels of blood cells in the retina, and this changes according to IOP changes, systemic perfusion, and time of measurement. But we know that the lower baseline peripapillary vascular density correlated with faster RNFL progression. And this was the result of a study of 27 months of follow-up. And this was independent of the primary RNFL thickness. This means that the OCTA might be useful in providing a prognosis for the risk of progression. We also know that the presence of microvasculature dropout correlates with faster RNFL thinning and visual field progression. The take-home message, OCTA is non-invasive dye-free method to assess retinal and optic nerve head vasculature. The vascular density is the most important parameter. The vascular density significantly is reduced in peripapillary and macular region in glaucoma patients and glaucoma suspects. And the microvascular dropout perfusion defect may be present in glaucoma eyes. The pros of the OCT are, in high myopic eyes and in severe glaucoma, we have a better correlation with visual field than the conventional OCT. We have lower floor levels till no floor levels monitoring, which is helpful in monitoring severe glaucoma. And the OCTA might have a prognostic role. The contras are the diagnostic ability, which is lower than the conventional OCT, the low reproducibility and repeatability, which is lower than or might be lower than the conventional OCT, and that the vascular density varies according to IOP, peripheral perfusion, time of examination, and other factors. Thank you.
Thank you
Thank
very
you, Dr.
much.
Samar. You are on time.
Very good. Is there a way, Samar, for you to tell reliability in these scans? I forget to say if snapshots, reliability, indices, or anything.
The defects which we see in the conventional OCT are available in the NG-OCT. The problem is the time to take the examination is longer. We need 2, 3, 4 seconds to take the examination, and the torsion movements of the eye and the concentration of the patients plays a very big role. So this is the problem with the reproducibility. There are new techniques which are trying to do with examinations in faster time. There are new techniques which are trying to make a better concentration, eye trackers, but we are still testing this.
Okay, perfect.
Dr. Samar, I find this is a good correlation between the advanced visual field and OCTA. When this is the advanced mean, this is how much the MD on this is in the early visual field defect on early glaucoma, or was a good correlation, or OCT more correlation with the
This
OCTA?
was more seen in the advanced glaucoma patients, but was also available in the mild glaucoma patients. But as we have seen, the loss of the floor effect in the OCT angio makes it relatively suitable for the patients with the severe disease. We have always the problem with the severe glaucoma and the OCTs where we see the floor effect and we do not know if we have a progression, especially the patients who are not cooperative on the visual field. And this might be an aspect where the OCT angiography might be helpful.
But this is not related with the visual acuity for the patient, if it can concentrate centrally or not. This is super.
This is a very important aspect that the patients should be able to do the examination. We are speaking about visual fields, but we are speaking not about patients who lost their central island.
This is the central island.
Exactly.
Should be.
This now is good. Welcome Dr. Basil Qaddura, who will speak about all the way from Sweden, who'll speak to us about OCT abnormalities, what is not glaucoma, or are you going to go for the Scheinfeld tomography?
No problem. This is
whichever you wish. He has two topics.
I'll start with the short one first. Thank you so much for your invitation. I'll share my screen in a moment. My first talk is about Scheinfeld tomography and Guttata, what a glaucoma specialist needs to know. I have no financial disclosures, and I'll start with this study, which published last year in ophthalmology. Researchers in Mayo Clinic tried to predict the prognosis of Fuchs endothelial dystrophy by using Scheinfeld tomography. And they included three methods. The first one is the tomography maps with the bathymetry map and posterior elevation map.
Sorry, Dr. Basil, you are not sharing the full screen. You will have two screens.
Okay.
Yeah. The full screen you are sharing on the.
Screen 2. Okay.
You open the presentation.
What about now? You see nothing, maybe?
The presenter view, if you can move to just the regular view.
The problem, I have 3 screens here. That's it, a little bit sophisticated, but I'll fix it. 1 minute. Screen 3, and here, now. What about now?
It's okay. Go
ahead.
Perfect.
Yeah.
Perfect. Yes. So the first one was, as said, the Scheinfeld tomography with 3 indicators. The second was so-called corneal backscatter with confocal microscopy, and the third was the central corneal thickness with ultrasound. And they included about 100 patients, and they did say that there is some progression if corneal edema, clinical edema showed up, or if the central thickness increased about 5% with 2 visits, and they followed up the patient over a 5-year period. As I said, they tried to examine 3 indicators with the pentacam HR tomography and corneal bar scatter with confocal macroscopy and the CCT. And here we can see, I'll just use my pointer, that there are 3 indicators in the pentacam. The first one is so-called loss of regular isopax, when they are not circular, or when they are not parallel with each other within 4 millimeter circle. The second one is displacement of the thinnest location, if it's not in the pupil center, or if it's 1 millimeter from the pupil center, or not in the lower temporal quadrant. The third one is from the elevation, back elevation map, and they look within 4 millimeter as well. And they look for focal depression with minus values, like here. So we can see this patient is progressing after 5 years or 7 years with more irregular isopax, more focal depression, and more displacement of the thinnest location. The outcomes, the most important one was how the progression is after 5 years, and regarding the pentacam indicators, you can see if there is no indicator, it was 7% progression after 5 years, the cumulative risk. If it was 1 or 2, it was about 50%. If all the 3 indicators were present, it was about 90% of progression. The most important finding was the progression after routine cataract surgery. And again, it was 4-year follow-up. And if none of the indicators were present, so it's 0. If 1 or 2, it was about 50%. If all the 3 was about 75% after 4 years. So you might say, what have this to do with the glaucoma? We know that Fuchs endothelial dystrophy is related to glaucoma. When one of the largest studies examined the issue with about more than 1,600 eyes, and they compared them. They did have Fuchs dystrophy, and they compared them with control group relatives who don't have Fuchs dystrophy. And they did have a higher prevalence of glaucoma or ocular hypertension. But the most important finding was the grading of the Fuchs dystrophy. If it's grade 4, it means gutata located more than 2 millimeter diameter from the center. So it's about 11% higher prevalence of glaucoma or ocular hypertension. So they recommended screening for such patient, grade 4 or more. And we know that endothelial cell loss is associated with cataract surgery, routine surgery without any gutata, with 4 to 16%, but it's more if the patient has gutata. And traditionally, we use the specular macroscopy and the pachymetry to decide if only cataract needed or cataract combined with the endothelial keratoplasty in such patient with such cut values. And we know that glaucoma itself is a disease who means endothelial cell loss. We know that even using drops like timolol, I'm not speaking about carbohydrate inhibitor, no, timolol, it's about 3 to 5% endothelial cell loss per year, which is 10 times greater than the normal subjects, 0.3 to 0.5. We know that corneal decompensation is associated with various procedure, PI, repeating SLT, and we don't need to speak about the filtration surgery or shunts and endothelial cell loss. Some studies, like Keith Barton group, find about 50% endothelial cell loss in the periphery and 40 in the center after tubes, 5 years after tubes. What about mix? The only mix which now is non-associated with endothelial cell loss is the CyPass. It's withdrawn from the market. The other studies didn't show any significant difference with the control group, which is cataract operation, phaco. So take home message, CCT is not enough because sometimes we might have a patient in the evening. We know that in the morning is the thickest, so sometimes we don't measure it centrally. Specular microscopy might be a very good way, but it's not available every way. And we might use it in the prognosis post-cataract in the short period, but we need something in the long period for glaucoma, and here we can and might use the Scheimpflug imaging. Thank you so much. This was my first lecture. Any questions?
Thank you, Dr. Basil, for this presentation. Then every patient should be also for focused dystrophy to make pentagram now. I
recommend grade 4 or more. I do it to just, especially if you want to operate the patient, you want to, especially here in Sweden, if you want to operate the patient with endothelial keratoplasty, it might take 1 year, 1.5 years. So I do say to the patient, there is risk of progressing corneal edema after the surgery or after repeating SLT, for example. So I do it, but we need more studies indeed. We need more. This was one study with a small group of patients, but we do need more studies, I think.
But the correlation between the corneal thickness on the endothelial cell account, when this is more than 640, as this is by Professor Bagula mentioned, on the low endothelial cell account, is not sufficient on. It
might be okay for the short term, like the cataract surgery. Yeah. But it's not the best way for the long term. You know, we have studies 2 years after the surgeries, but we don't. You know, the glaucoma patient, it's a journey with the patient. So you need to tell him from the beginning there is risk so, and it could be so. I think like this study of 5 years follow up. That's good. You mentioned us about the timolol, the 3 to 5% is the endothelial cell account. You find any study about the dorzolamide, or there is a difference between dorzolamide or benzolamide or systemic carbonic anhydrase inhibitor? Not significant, but there is a little bit increasing, of course, but not significant. Not more than timolol? This study is for healthy corneas, 3 to 5. It's not for Guttata patients. Yeah, for the healthy cornea for the glaucoma patient. What about the glaucoma, the low endothelial cell account? This is Dr. Abdulwakil, we face here in Oman is most of our patients with very low endothelial cell account. This is corneal Guttata is so much common that what we see in outside of this country. Of course, even here. But as I said, the most studies just studied the issue with the healthy corneas, 3 to 5%. And there's no, as I read, there's no significant difference between the timolol and carbonic anhydrase inhibitor. But yes. So shall we continue to the other lecture? Now it's please. So screen 3. You didn't stop sharing the screen to finish the first presentation. 1 minute, just 1 minute. Yeah, now. Yes. Screen 3 and yeah. So can you see it? Yeah. Okay. Can you? It's one screen, right? No, there's 2 screens. Okay. Sorry. 1 minute. In this time, until you still sharing the screen.
Dr. Ali, but corneal endothelial loss, even with a pars plana insertion of, or a sulcus insertion of an Ahmed tube shunt. So even that does reduce cell count.
Yes,
It's only good solution when the patient is pseudophakic and can you enter in the posterior chamber. But in this case, is always you find is better if the patient have anterior synechia. Otherwise, if you enter only on the posterior chamber, there is rubbing for the iris with the tube is also more risky for the continuous uveitis and problem.
Okay, go ahead, Dr. Bassel.
Yes, which screen do you see now, 1 or 2?
No, 1. Now is okay.
Excellent.
Now is okay, Dr. Bassel.
So my second lecture is rapid fire cases. Just feel free to say stop when it's end of time. I have a lot of cases, but I'll just try to be as fast as possible. And again, I have no financial disclosures. I just take my laser pointer here. So when it's red disease, you know about red disease and green disease. Red disease can be because of artifacts or normal anatomy outside the normative database or non-glaucomatous injuries or glaucomatous. So I'll not be talking about the first and the last, but because they need another lectures, but mainly about the second and the third. And I do recommend this this study, this publication, very nice publication of Randy Cardon, when it comes to artifacts with the normal anatomy, and this link for the neuro-ophthalmology cases, very nice cases. So don't forget the green disease. Green disease means when you see that it's green on the OCT, but the trend analysis is going down. There's a case with a 50-year-old family doctor patient. You can see that within 4 months, there was significant reduction of the RNFL, mainly inferiorly. In the right eye, mainly in the left eye was okay. And it's confirmed also with the GCC. You can see here the thinning of the GCC. So the max pressure was about 18-14, but mostly was about 12-11, and he just has one doctor said to him it's normal tension glaucoma, but we did MRI brain and orbit without any abnormalities. Here you can see larger build of the optic nerve. You can see how there's more thinning of the rim here compared with the rim here, and you can see the typical nasal step. But look at the C nerve 4 months ago. It was a little bit swollen, and look here in the near infrared image. It was a little bit of choroidal folds and very thick nerve fiber layer. So this is a case of papillitis indeed. We take some lab, and he was positive for Borrelia. So it was Lyme disease, and he refused to have LP, but we treated him with Dixocycline 2 weeks. And do look always at the thickness of the GCC. If it's a neurological disease like glaucoma, you can see thinning mainly in the GCL. If it's vascular, you can see thinning of the whole inner retina, not just the GCL. What about the normative database? We know that our machines doesn't have a lot of patients. We use TopCon and less than 200 patients, not a lot of myopic patients, not a lot of our Ethinity either. So do choose wisely your device according to your Ethinity maybe. And there's another case. It's a patient with hyperopia. The max pressure was 27 right eye, 22 left eye, nearly normal corneal thickness, and we did SLT in the right eye for ocular hypertension. The visual fields were okay, but came to me for 2 months ago with normal within normal limits in the IOP. But look at the near fiber layer. There is thinning inferiorly and temporally. So is it something we need to treat? Here I wanted just to emphasize that the patient is hyperopic. So she's having so-called nasal displacement of the retinal near fiber layer bundle, both inferiorly and superiorly. Therefore, the device is comparing this bundle this here with the normal subjects, and this is normal thickness here in the thickness map, but this map showing red disease because of comparing with normal subjects who do have the bundle in the normal position here. So think about it, look at this slope, T-SNIT or instant in your device before just deciding if it's red disease or not. And I wanted to make sure that the temporal is also artifact, so the GCC complex is all right. So we just managed here with OCT after 6 months. Another myopic patient, ocular hypertension about 22. Shall we treat or not? Here you can see that the thickness is okay, but look at the yellow here, it's maybe thinning. The red here, it's thinning, but again, it's a patient who has temporal displacement because she's having myopia. In myopia, it will be temporal displacement of the retinal nerve fiber layer bundles. So think about it, look at the T-SNIT here and look if it's displaced temporally, inferiorly, or superiorly before deciding if it's thinning or not. A couple of words again. Think, just do your job and ask the patient or look at the records of the patient of myopic, or how the size of the optic nerve before deciding if it's real or not. Another case, this is a 17-year-old patient, referral from the optician with the vision is 0.5. And this was since the childhood. So we did OCT and visual field, and you can see temporal thinning of the NFL. You can see the secocentral defects and the visual field. Here, the more central defects and the central defect of the GCC. So I just, before planning for MRI or other tests, I just asked the patient, do you have any relatives with the same condition? He said, yes, my father and my brother. So it's a case of DOA, dominant optic atrophy. Another case I met 3 years ago, and she's coming with typical symptoms of opticus neuritis in the left eye, with the counting finger vision in the left eye. You can see the OCT showing maybe bitemporal defects, but I did then some literature, and they said that it can happen because of subclinical episodes, maybe in the right eye. But I wasn't so convinced, so we just refer her to the neurologist. And here you can see the visual field. It's obvious that counting finger here, but why here she sees she saw 100%? Why she's having this defect? So the MRI showed a so-called MS lesion in the optic tract. So it is optic tract syndrome, and when including left side opticus neuritis. So in optic tract syndrome, you can see that the contralateral eye, if we have a lesion in the right eye, so the left eye will have RABD and will have temporal and nasal thinning of RNFL. But in the same side, we'll have a defect which mimics glaucoma. So think about it when you have a patient with upper and lower defect, but nasal temporal in the other eye. Think always about the optic tract syndrome. This is a patient who was referred from private ophthalmologist to us with diagnosed normal tension glaucoma. The pressure was about 15, and the visual field just showed a little bit temporal wedge in the left eye, maybe normal in the right eye. And you can see here the OCT showing thinning superiorly and temporally in both eyes. So the resident came to me and asked, what should we do? I told he'll just ask about the GCC, and in the GCC you can see how it's binasal defects respecting the vertical line. So but you can see here, maybe it's not obvious, but there is a little bit of disc hemorrhage here inferiorly, but the defects are superiorly. Therefore, I wasn't so sure that it might be normal tension glaucoma, but I wanted to ask for MRI in the brain, and it showed a microadenoma in the pituitary. this case has microadenoma in pituitary and referred to us from the neurosurgeon for visual field and vision before this is the surgery. You can see that bitemporal defects here, and it's conferred by binasal defects in the GCL or GCC. But you can see after the surgery, the GCC is getting better indeed. So can we use it as a prognostic factor? Many papers have just showed that, and you can see here the visual field at the same time of the improving, showing bitemporal defect again, but after 3 months, for 2 weeks ago, showed tremendous improvement indeed. One thing you have to look around is a patient having a PRP previously. Many papers have just prescribed this, describe this as even with normal IOP, the thinning of RNFL with time can happen after PRP. So always think about the Pascal system, the patterns scanning laser photocoagulation in patients with glaucoma, because it has mild and better prognosis when it comes to RNFL loss after the procedure. Here's a patient referred to us. You can see very normal RNFL and GCC, but the patient did have stroke in the left side of the brain, with so-called pie in the floor defects, and it takes about 2 to 5 years to be shown in the retrograde effect in the RNFL, because the synapses happened at so-called lateral geniculate body. So this retrograde injury doesn't happen with 1 or 2 months, but it takes time. Do I have some time, or shall I just... I have just 6 slides. This patient I saw 2017. He has epidermoid cyst behind the chiasma, and you can see here the hominin defect, but I couldn't do the visual field then. So I just asked for the GCC. You can see that it's getting worse in the right eye, the other side, and already in the left eye. So we repeated the visual field about 6 months, and you can see that in the right eye, it takes 2 years to be reflected from the GCC to the visual field, and in the left eye, it was already destroyed, unfortunately. My last case about 39-year-old white man with so-called punctate inner keratopathy and ocular hypertension. Max pressure was 23/29. It came to me with IOP 22/25 in the left eye. He's hyperope, and cap to disc ratio about 0.2 right and 0.1 left. You can see here the RNFL and the GCC showing defects. But look again at the bundles. He's hyperope, so we do had also nasal displacement of the bundles, and you can see here superiorly. Here it's GCC showing some segmentation error indeed, but you can see superiorly that there is so-called split in the nerve fiber layer, and about 15 to 20% of people have this normal split, anatomic split. So the device is considering this as defect, but it's not. And I did take OCT angio to just confirm that there is no defects in the lower side in the left eye. And you can see the density here very, very nice, and the flow is very nice as well. And always gold is old. We have old pictures from 2016. You can see the nerve fiber layer is very nice and not changed, as well as the excavation in both eyes. And with this, I thank you so much. This is a patient who has a heart in her optic disc. She's used to drive 500 kilometers to come to us. I do think the optic nerve is the window for the soul, not only to the brain. So thank you so much for your attention and for allowing me to have so much time.
Thank you, Dr. Bassel, for this nice presentation. Please, any question from the panelists?
Yes, I have question for for Dr. Basil, please.
Which Basil?
Okay. We have two Basils
Basil
here.
trabeculotomy or Basil OCT now?
OCTA.
Dr. Somar.
Dr. Somar, yeah. Sorry for Dr. Somar. Dr. Somar, we know that we have difficulties in diagnosis of perimetric glaucoma. Do you think OCTA has any role to help in that?
There are studies which we do not know, but there are studies who try to examine the half of the retina in patients who already have visual field defects, but only in one half of the visual field, and they try to examine the other half of the visual field, which is normal. We do not have long-term studies where we see the patients or the glaucoma suspects which develop visual field defects. But we have these patients as an indicator, and they really found that the vessel density in these patients was reduced despite that the thickness of the nerve fiber layer was normal. This might be an indicator that the OCT angio might have a role in diagnosing patients with a preperimetric glaucoma, but we still do not have long-term studies.
Okay, thank you very much. Thank you.
Okay, that was a great session. And with this, we'd like to conclude our session for today. I'd like to thank our speakers for the wonderful presentations and for taking the time to be with us today. And please take the time to also tune into the keynote lecture with Dr. Lemele Eswed at 9:35, I believe, local time today. That should be very interesting. So please do take the time for that. But thank you all very much. And thanks to the organizers as well as DocMode for their support.
Thank you.
Thank you very much.
Thank you.